Hello everyone. This is a topic of anatomy of regional anesthesia, especially for lower limb and renal surgery. This is for those who are planning to learn regional anesthesia, especially ultrasound guided one, and regional enthusiast. There is something for everybody, including expert. So let's go to the next slide. This is what you get to do in a renal surgery if this patient is a donor. Incision is there, you can see. So what are the block appropriate or is going to work there, we'll discuss here. And this is the recipient of renal transplant surgery. And since the incision is near the inguinal area, so what would be the best block for this? So we know spinal and epidural, they worked for ages, and why we are diverting to other newer blocks. The issue with the renal surgery patient is they are not only on heparin and coagulation issues, so chances of getting the theoretical or practical, whatever, the risk of spinal hematoma or epidural hematoma is always there. So lot safer blocks which has come up like quadratus lumbarum block, transverse abdominis plane block, even thoracic paravertebral block, probably we don't know, but is it the best one? So this is what the trend is moving. Now, thoracic paravertebral, is it a perfect solution? The answer is nobody knows yet, but looks promising. Now this is the anatomy review of thoracic paravertebral block. It's one of those lateral pictures taken. You can see the ribs and you can see the somatic nerves started coming from the sideway from the vertebral canal. This is where we are trying to block the thoracic paravertebral. Now this is a little more rotated film. You can see the ribs as close to the spine as we find the transverse processes and pleura. We are going to deposit in between those transverse processes and above the pleura. There is a risk of pneumothorax, we all know that. It's a deep block and it has got its own risk and limitations. So let's review first, then we'll go ahead. So this is more rotated film, I mean on the straighter way, so you are looking at the back. You can see each between the ribs, each nerve roots are there. So you know T10, T9, T8, okay, these are the area of block what you saw in on the first beginning slides, that where you would going to put the block and which area is going to supply that area. So this is one of those 3D, I mean picture of muscles which is there. You can see the erector spinae and intercostal muscles. Beyond that you will see the pleura. Now exactly how does it look in ultrasound? We'll just see it. Okay, so this is where you are going to put the probe. You can see the triangular red area. You can, this is in between 11th and 10th. You can go one step above, 10th and 9th. From there would be the appropriate sites. You can do a single block or you can do a multiple level block to get more precise if there is a doubt in the spread of the local anesthesia. You will be seeing all those things under ultrasound vision. Now let's see how does it exactly looks. This is a picture as I showed in that triangular. This is first the lateral part of the rib away from the spine, 4 to 5 centimeter. You start scanning it. Now if you can see the depth of this picture or the ultrasound image is up to 4.4 centimeter on the right lower corner. Alright. What are the structures you are seeing is probably the erector spine muscle up at the top of the screen. Let's move it. Alright. Now what I am seeing is two impression of ribs. One rib roundish and the other one is it started coming. So what you are seeing is now two ribs. Alright. So erector spinae muscles at the top, in between the ribs is the intercostal muscles. I'll bring my probe from lateral to medial. If you see, the depth is increasing now. So now I am in the even the rib, which is become the same rib will become transverse process by squarish appearance, and this is the area where I will give my block. I am close to the spine now. I can see the pleura, the pleural sliding, everybody knows. Now I came back again, you can see it's coming, I mean the depth is increasing and decreasing. When it is the deepest, there is the area, and the square is looking where it ends is the vertebral, I mean transverse process of vertebra. So at this place I am going to give my block. Alright. So we'll take another thinner patient and see how does the transverse process looks. Alright. So you see, this is a very thin patient, and you can see one rib here, other rib here, and you see the sliding pleura. Alright. Just above the pleura, you have to bring your needle from one of those angle, and you have to deposit the local anesthesia, pressing this pleura down. Alright. So all the time you have to look at your, we'll post a proper thoracic paravertebral block with vision in the next presentation. Alright. So basically, where in this static image, the brightest structure downmost is the pleura, which was sliding, and this is one part of the rib in the left side. On the other side, it's a complete rib-like structures is seen. Actually, I have gone deep. It is C at the 4.8 centimeter mark. So these two ribs-like structure, which is looking like ribs, is actually the transverse processes of the vertebra. So I will bring my needle here, and there is a definite gap. You can see there. I will deposit the local anesthesia in above the pleura, in between the ribs, in between the transverse processes. There are no more ribs now. Okay. So again, from top to bottom, you are seeing erector spinae, and in between the transverse process, probably some remnants of those intercostal muscles and pleura, which was sliding. Alright. Tap block went out of fashion in renal surgery in two of the major studies, which they found that there is no significant morphine sparing, especially for the renal surgery patients. Alright, I am talking about donor. Alright, there is one more block called quadratus lumborum block. The video, and there are 3 videos in our website. You can go to quadratus lumborum block in anesthesia section and review it. Just anatomical review. They are quadratus lumborum 1, 2 and 3. All are there. So you can review there. So this is what happening. What you are seeing is sacrospinalis or erector spinae muscles. This is the quadratus lumborum muscle close to the vertebral body. The quadratus lumborum muscles close to the where is it? Okay. So quadratus lumborum muscle, as you can see in the picture, and this is the latissimus dorsi. You are going to see all these three muscles during the block. Alright, so let's go to the next slide. So here you can see the quadratus lumborum 1, quadratus lumborum 2 and quadratus lumborum 3. All the three blocks where exactly to be deposited, you can see here. What is most important to note here is to see thoracolumbar fascia. There are anterior, middle and posterior. It is worth reviewing before doing a quadratus lumborum block. Why you need to know that? So here there is one more picture where you can see the quadratus lumborum muscles and psoas major muscles. In between them is the anterior thoracolumbar fascia, the anterior most, which is where it is most important that your needle has to come there and you deposit your drug there, and this is where the ultrasound guided quadratus lumborum block, one of those author has described. This should be the position, and this is how you are going to give the block. So we finished the quadratus lumborum, thoracic paravertebral, and bit of old spinal epidural. Why you should not be doing that. Now, what are all those lower limb blocks or technique commonly done or you should learn? Now, most important of all this is the femoral block. Okay, a mid-thigh femoral, or some say is the adductor canal or saphenous nerve block. Obturator not commonly performed except for those people, those who are going for urinary bladder tube or BT surgery for obvious reasons. Sciatic nerve block is important. Popliteal is one of the most important block you should know, and popliteal nerve block in the popliteal crease, ankle block, lumbar plexus block and sacral plexus block. In due course of time, we will cover all these blocks one by one, but as this is a gross overview, let us see what we have in this presentation. So what are the, if I give you a chance, that what are the two most important blocks you should learn? They are femoral and popliteal sciatic. This is my opinion. Why these two? Because most of the lower limb surgery would be covered by these two. What are the most peculiar things about this block we'll discuss. Why most of the people, although femoral nerve is a very superficial nerve, struggle to see the needle and nerve during the block. Let us discuss femoral nerve block. So, little bit of anatomy. What you are seeing here, the thickest nerve is in the back side, and if you see the femur and follow the femur to the pubis bone, in between there is a thin looking nerve is femoral nerve. Actually, the femoral nerve is a flat ribbon like nerve which can be up to 2.5 centimeter. It can be up to 1.5 to 2.5 centimeter, they say. Alright, but here in this anatomical depiction it is little less. So you just see it here. I put the iliacus and psoas muscle here, and the nerve sitting over iliacus has to be femoral nerve. Actually, if you think rationally, the femoral nerve creates an in a gap, or it's its own impression over the iliacus muscle. If you see the iliacus muscle by on ultrasound, there will be in a notch sort of thing. It's easy to find out that if you are not able to find out the femoral nerve, this is one of the way. You follow the top of the superficial or anterior surface of iliacus muscles, then you see that suddenly there is a gap, and there is the femoral nerve. Alright. So here the femoral nerve is more evident. Now if you see the thickest muscle which is visible here is rectus femoris. Why I am talking about rectus femoris here? Sartorius is it's coming like a ribbon, and rectus femoris is next to it. It's a very thick muscle, powerful muscle, and if you follow the rectus femoris towards its origin, a thin nerve is lying and coming down. That is the lateral cutaneous nerve of thigh. It's leveled here, rectus femoris muscle and the lateral cutaneous nerve of thigh. So these are the two muscles you should know, and you have to identify very clearly the iliacus, sartorius, rectus femoris, and lateral to rectus femoris is tensor fasciae lata. Why I am taking these four muscles name? Because there is a disease called meralgia paresthetica. Everybody knows it now because of the tight pants and jeans of fashion which is coming. That this meralgia paresthetica has come up in a big way. Many patients, especially I have been getting a lot of requests for this lateral cutaneous nerve of thigh block, and those who are having neuralgic pain due to the whatever reasons, obesity they call obesity disease and tight pant disease or whatever. So this is also very important to know, the lateral cutaneous nerve of thigh. So we have femoral here and lateral cutaneous nerve of thigh in the same picture. Now let's go to the ultrasound. People think that femoral nerve is lateral to femoral artery. It is not true. It is not always close to the artery. If you see this patient's femoral nerve, the artery is not visible. What you are seeing here, artery, you just saw, it is far away from the artery. So it is far up. Okay. So needle is coming, and it has come. I am below the nerve now. I am going to deposit some of the local anesthetics, and once the local anesthetic is deposited, the nerve has appeared very nicely. So this is the femoral nerve. You can see here that artery is not visible, which is the left side of the screen which initially you saw it. You can go back and review and play it again. The blackish structure below the needle, then towards the right of the screen, if you see, this is the iliacus muscle. As I said, femoral nerve has to sit like creating a notch over this iliacus muscle. There was one slide I said that what are the peculiar thing about femoral nerve. Like if you see, when we do the femoral nerve block, there are two fascia we do penetrate. Fascia lata, the thicker fascia what you are seeing upstairs, and fascia iliaca, the iliacus muscle fascia. So these two fascia has to be penetrated. Since these two fascia are very bright and needle also is bright, so unless you decrease your brightness of your screen or ultrasound setting, you are not going to see the needle. These are equi-bright, so that is the reason most of the time why you have difficulty seeing needle while doing a femoral block, being a very superficial block. So this is one of the reasons. Decrease the brightness, you will see the needle in a better way. Now this is another femoral block. You see the screen, the artery is close to the nerve, right? It's very close. So interpersonal, person variability is always there. The iliacus muscle is totally black here, so you are seeing the needle much better. But you can appreciate the needle is not very clearly visible because of those needle-like fascia which is there upstairs. So if you decrease the brightness, you might be able to see the needle better. So this is one more. Again, here artery is not on the screen. So I am going probably at the corner of the nerve. All right. So what I am trying to show you is that there are two divisions of femoral nerve there. If you do a block properly, after some time, most of the cases, you can see these two. Can you see the femoral nerve dividing into two? Not exactly this, but I will show you in some of those block which I am going to post, if you give local anesthesia good amount above, the anterior division and posterior division, they separate out, and that is the nerve block which is going to last much longer. So let's go to sciatic nerve block. So little bit of anatomy. This is how it looks. So two structures has to be remember that below the sciatic nerve, the muscle here below it, if you are seeing from the back, the deepest muscle where we are talking about intertrochanteric or transtrochanteric or intertrochanteric level, you see that muscle, it's a strap-like muscle, it's called quadratus femoris. And the next slide which is covering is gluteus maximus. So what exactly you are having is that this is the nerve between gluteus maximus and quadratus femoris. At that level, we do the conventional at trochanter level sciatic nerve block. So the good thing about it is easy to identify is that muscle fiber of gluteus maximus and muscle fiber of quadratus femoris, they are like in a opposite direction. So one, if it is appearing bright, one has to appear dark. This is what happening. In the middle of the screen, that is the sciatic nerve. Okay. Just below the sciatic nerve, if you see carefully, this is a quadratus femoris muscle, and above it, it's a gluteus maximus. In between that, you can see the pulsation, that is the inferior gluteal artery. Okay, if you see carefully. So these two muscles are, the fibers are oppositely directed. So one has to appear lighter than the other. So, and gluteus maximus, they say that there is fibrous bands are there. So they appear hyperechoic, and quadratus femoris is hypoechoic. So one is quadratus femoris always appears dark, and if you create that darkness with your angulation of probe, you can see the sciatic nerve easily. So this nerve is in between two muscles, gluteus maximus and quadratus femoris, and they have different architecture. So next is the popliteal sciatic. As I said, this is one of those most important block for the lower limb surgery, popliteal sciatic. So most of the time I do selective tibial. I will tell you why. So let's review the anatomy. This is how it looks. This is the popliteal fossa, and you see the artery and vein above the first, the deepest structure. In the ultrasound screen will be artery, and then comes the vein, and most of the time vein is not visible because of our ultrasound probe pressure, and top of the vein is the nerve. So they call it snowman above something, whatever description they can give. So this is the anatomical description. Now, if I move my probe little down from the popliteal crease, this is what I will get. So these two nerves, the smaller one is common peroneal and the bigger one is tibial. If I go up, it becomes sciatic. Now they are separate. Why selective tibial? The bigger one is tibial. I do always the tibial nerve block. I will tell you why. Okay, now it has become sciatic. These two, you can move your probe up and down. So, two nerves separating in a different, you can see that. All right. So this is the popliteal sciatic, the two nerves. When we go up, it becomes sciatic. When we go down, it becomes two nerves, common peroneal and tibial. So this is a selective tibial nerve block which is being shown here. So you can see the common peroneal. It is separate and far away. I brought my needle down below, and now once I spread was satisfactory below, I'm trying to go above those, above the, okay, I'll try to go in the next few seconds probably. All right, now I am trying to go above the tibial tibial nerve and create a donut or whatever. That is not required, but it's good to have surrounding all over the nerve, any nerve. So this is it. This is only the tibial nerve. I mean, common peroneal, we have not done anything. Why I did that? Because most of the posterior knee pain in the total knee replacement surgery, it's mostly done for total knee replacement surgery, it's coming probably from tibial nerve. I have now never encountered a complaint of any pain in TKR surgery by doing selective tibial nerve block. With the advantage that since the patient's common peroneal nerve is not blocked, the patient will not have a foot drop. So he will not complain that his leg is completely numb, although he will remain pain free. So this is one of the advantages, that you do a selective tibial nerve block and you get away with your posterior knee pain. You do not do a foot drop, which is very uncomfortable for the patient. Thank you very much. This is it. This is what this is a complete, overview of those nerve block. We'll go one by one in the website in detail. Those who are interested in learning, please register. Thank you very much.